Well, folks, it's really a pleasure for me to get to meet Dr. Ameish Govindarajan. And hopefully I did not slaughter your last name, Ameish, but I am unfortunately known to sometimes mispronouncing and misspelling names. So I apologize in advance if I did. But it's such a pleasure to have you on Healthcare Unfiltered. Now tell me, did I say your last name incorrectly? You could tell
You
me.
said my name perfectly. Dr. Govindarajan is,
Okay,
yes.
Govindarajan. See, you, the way you said it is the right one. No, I'm actually very sensitive about this. I believe that people need to take the time to know how to pronounce someone else's name. And I think it's important. It's okay to make a mistake, but you ask the person, how do I actually say it? But I do believe people must take the time. Now, you may choose, call me so and so, and that's fine, but you get to decide. Ameish, welcome to Healthcare Unfiltered. Really appreciate. This is the first time we meet by Zoom, although we've corresponded a couple of times by email. So I appreciate taking the time. I've invited you to the show because you wrote a very emotional and moving piece in the Journal of Clinical Oncology section, The Art of Oncology, and you called it Chasing Milestones.
Yes.
Before we get into the piece and what led you to write it, tell us just a little bit about who you are and where you are currently. Just let's make sure that listeners get to know you.
Yeah, absolutely. I'm a native of Los Angeles, California. I am currently a postdoctoral research fellow at City of Hope, focusing on the genitourinary oncology space under the tutelage and mentorship of Dr. Sumantha Paul.
And so you are a PhD by training, and or you're an MD or a PhD or both?
I'm an MD, yes, MD, and now I'm just doing research with the soon to be going into fellowship at Memorial Sloan Kettering for Hospice and Palliative Medicine, with the focus on the intersection of supportive care and oncology, and then eventually going into oncology, hematology, oncology as well for training.
Congratulations. So you finished your medical residency,
Yes.
and now you're doing a fellowship in GU oncology under this guy nobody knows about, this Monty Pal guy. I mean, we don't know who he is. Uh, I'm kidding, Monty, you better be listening to this. And then you're doing a fellowship at Memorial for Palliative Care and Hospice Medicine, and then you are going to go back to do hematology oncology fellowship.
Yes, yes, because I feel that this metric is really important, this intersection of supportive care and oncology, of meeting the metrics on improving patients' quality of life. So that's kind of going to be my lens of research in the future, and focusing on those quality of life metrics.
Was your decision influenced by your personal story, by what you have actually gone through over the past several years?
Absolutely. I think that my decision to go down this path of focusing on effective communication and also focusing on cancer patients has always been paramount to who I am and in my constitution after when I started residency. And I think that it's only highlighted and how should I say, augmented it more as I've worked at City of Hope, that this is the metric, or this is the place or arena where I feel that I would love to give myself to, which is focusing on this metric of understanding how do we improve patients' quality of life that are ongoing with their cancer treatment and their cancer journey, and how do we support them during this process, because as we all know that medications and treatment landscape is rapidly advancing, and patients are now living beyond the PFS, beyond the overall survival. And so from that lens, we need to be focusing also on cancer survivorship, of how they're going to cope, not only to the patient, but also to the family member as well.
So tell us a little bit how this all started, because obviously, you said your personal story influenced how you actually decided what your career path will be, um, you yourself were diagnosed with a form of cancer.
Yes, yes. When I was in the middle of my medical school education, and I remember I had this incessant cough that, was not being, after extensive, treatment with antibiotics and whatnot, it still was unrelenting. Eventually, it a CT scan actually happened, and of my chest, and it showed a cavitary lesion, uh, which for extensive bronchoscopy and whatnot, I eventually ended up with the diagnosis of stage 4 non-small cell lung cancer. And at that point and at that
Okay,
moment,
stage four. So it was gone. It has gone elsewhere.
yes, there was, just by the fact that there was a pleural effusion and there was some miliary seeding as well in the right lung, it kind of actually was already diagnosed with stage 4 at the time. And through that whole process and that whole journey, it flipped my whole life around of what was really important, what was the things that I needed to do to survive. And so I was really fortunate. Even my first oncologist, uh, he was very pragmatic and very, very practical speaking. But I think that what happened was, in my story, was that I still wasn't feeling heard in that piece of focusing on the treatment plan, but also understanding where I was in the situation of my life. And I think that was very distinctly different. And so when I
So
went,
tell me a little bit about this. You got diagnosed with stage 4 non-small cell lung cancer, and you were referred
Mhm,
to an oncologist.
mhm.
So you went to see the medical oncologist. How was your first visit or your second visit? Because what you're saying is you did not feel he was hearing you. Can you elaborate a little bit on that, and how was the conversation? What actually happened?
Well, I think that from my perspective, I think that he saw me as a colleague because I was a medical student. And so he was very pragmatic and kind of just focused more on the statistics and just the disease process itself, where it I felt that I wasn't being offered even a discussion or opinion on what should be of how I should be treated. And it wasn't actually anything because, in the perspective of oncology, he's a fantastic oncologist and very pragmatic. I think that kind of carried itself in my situation, which was I was looked as a young budding physician. And so therefore, maybe that was the thing that kind of was focused on more on the practicality and the pragmatic of what my staging was and what was the next treatment. And and we still didn't have all the pieces of the puzzle at the time. So making these judgments and statements, however true in the statistics, we still were pending certain important information, which was the genomic testing, and which kind of also highlighted an issue that I felt was really important because I was a South Asian male who was a non-smoker, and with, in my 20s actually having this diagnosis, I felt that it there needed to be more testing and genomic testing in my story, in my clinical story. Yeah.
And he wasn't discussing that with you, or he was?
Yeah, it was kind of still, it was an afterthought. And I think that was a moment where I was lucky and fortunate to have also a brother figure who was also a physician as well, and kind of say to me that if you feel that you're not being heard, you should seek second opinion. and see if that's a better fit. And that was the thing that shifted my thought, because generally what attending says to me is usually gospel to me as a medical student, and now, when I was a resident as well. But I think it was that moment where seeking that second opinion was actually the thing that changed my trajectory of my cancer care, my cancer journey. I really do believe that.
But the reason you sought the second opinion was not inadequate care. It was just you did not feel there was that connection.
Exactly. And I think that is the most important aspect of the story, because it was not about the care itself, because that's farthest from the truth. From his care was great. However, our connection was not aligned. I felt there was some elements of the lack of advocacy in my situation, and not having all of the pieces to the puzzle and making a statement, which is you have 6 to 8 months to live, was really hard for me to hear. And even though it is a pragmatic statistical truth, and from his lens and from his perspective. So I think that was the reason why I sought a second opinion.
In fairness to you, though, I mean, he basically gave you this number and you felt it was provided without adequate, complete information. I mean, you felt there's more to the story, and don't give me numbers until you get all of your facts straight.
Yeah, and I think that's the most important aspect in order for us to understand patients of how they're feeling or what they're dealing with. It's not actually not providing them all this information that is really important. It's actually, first of all, having 100% of the information before we make a statement. And the second thing is aligning to their goal of what they want to accomplish, and of just getting to know me instead of just saying the practical, pragmatic truths. And I think if we first focus beyond, if we pull back the curtain and we see that there's a patient here that's a human that has these aspirations and has these dreams, can we actually meet that metric by hearing what they actually want to accomplish? And then after that, by having 100% of our information, deliver our message so that we can get a better disposition and an optimized plan later on. And that's the most important aspect that I do believe that shared decision making is really important in oncology and often not talked about.
Yeah. How did you find the second opinion? Did you just rely on your friends, colleagues, because obviously you don't know him or her, you just asked around. How did you decide which physician you're gonna see?
Well, I was really fortunate because my older brother had some affiliation with a connection to a prominent thoracic oncologist, and figured out a way to. I was privileged enough to actually get a faster appointment, and luckily, I still remember that moment of meeting my oncologist and saying, "Okay, this is the person that really meets my metric." Not because there was any change of this treatment plan, but she understood and heard me of that. She just understood and heard me so much more of what I was trying to do. And I still remember that as a life-changing moment. The first question she asked me was, when are you applying for residency? And I was kind of shocked and thrown back, because here I'm expecting someone to just be very pragmatic and practical of tell me the statistics. But she didn't focus on that. She focused on what was my goal, what was my alignment to my goal, and then saying what was the next treatment plan or treatment course that could get you back into medical training, that could get you back into medical education. And that to me was tremendous.
Yeah, it's sometimes very difficult to define that human connection, but it's you know it when you feel it. It's hard sometimes to put it into words, but it's either it's there or it's not. And I do think it's so important between a patient and a doctor, because they are seeing you when you need them the most, and you gotta trust them.
Yes, I completely concur with that statement. As when I was in internal medicine residency, and I was often sitting and reflecting with my opinions or my treatment plans, not not having the full information and going and pulling the curtain and saying this is the plan or this is what we're going to do is not aligning to the patient's goal. So the first most important thing is obtaining all the information possible, and even from the specialist as an internist at the time, and then coming in with that approach of saying what is it that they want to, how do we meet their metric for their care. And oftentimes that will get exactly what I said, the best disposition and outcome for discharge and for outpatient care or whatnot.
So then she started you on therapy. Is that what happened?
Yes, yeah. So she started me at that time, my genomic testing came back. I was found to have ALK positive non-small cell lung cancer. I was started on a targeted therapy, um, and I was able to get back to my education. Yeah.
And are you still on that treatment now?
No, unfortunately, it actually failed after, I believe, I think around maybe 10 months or so. It failed, and then I had to start receiving systemic chemotherapy. And at that time, and during that time, I started to receive systemic chemotherapy. I I was after during that course, there was an option to get off standard of care, routine standard of care, and receive another targeted therapy at that time.
On a clinical trial, you mean?
On a phase 1 clinical trial, yeah.
On a phase 1. Tell me about this conversation that you and your oncologist now, that drug failed after 10 months of therapy. You started on chemotherapy, and there's appears to be some other drug that came on, but you had to stop the treatment and get on a clinical trial. And phase 1 clinical trial is probably not something that you had thought you would be on. How did the conversation go? If you can go back in memory to that discussion that you had with your oncologist about the clinical trial.
Well, I mean, I still, I was scared. I remember hearing her bring up the idea, and I was a little bit fearful, saying, "Hey, we are already on standard of care treatment. Let's continue these, other cycles." And she said to me, "I think this would be the best case for us." That was the moment. This is the best treatment solution for us. That I think that this will really effectively help you. And it was a big leap of faith, to take that, to drop standard of care to join this clinical trial. I still often think about, why did I do that? And I think it was really on the element of trust. She said, "Hey, this will get you back into the clinic. This will get you back into your training. This will get you back into focusing on what you need to do, what you need to accomplish. And by doing so, yes, you're going to be having to come in once a month for this, for optimization and just making sure that all the labs are good and whatnot. But this will help you get to the next end result. And I was so fortunate for that, because that's the therapy that I'm currently on, and it's working great. It's wonderful. I have no evidence of disease.
How long you've been on it, Ameish?
I would say, I'm not sure. Let me think.
It's okay. I mean, but it appears to be like several years.
Yes, several years. I would say several years. Yes.
So congratulations, obviously. This is amazing. I'm
Mhm.
so happy to hear that. But when she was telling you about a phase one clinical trial, is it fair to say that a phase one clinical trial is not the type of trial that you can guarantee it's going to work, or it's going to really be the one that's going to get you in clinic? I mean, a phase one clinical trial, usually we still don't know how effective they are. That's why they are in phase one. So I'm
Mhm.
a little bit surprised when she said to you that it's going to get you this, get you this, get you this. Seems like she was more certain it's going to work.
Yeah, it's interesting. I think she really understands the ALK tumor biology, and she felt that this was a very good target TKI that could prolong my survival, and felt that way. And again, she always says to me, I am still an anomaly of most patients that are, that have received this TKI, and I'm super fortunate to be continuing on this treatment. Yes.
Because you could have, I mean, technically speaking, when you go to Google and Google phase one clinical trials and how they are designed and their dose finding studies, I mean, they're basically looking at the
Mhm.
maximum tolerated dose, and you could have easily declined participating in the clinical trial and say, I'm going to stay on standard of care. I don't want to be on a phase one experimental therapy. What made you decide to get into a clinical trial?
Because I truly believe in the research, and I do believe that research saves lives. And it also, what I think is the most important aspect is that if you're lucky and fortunate to join a clinical trial, it doesn't preclude you from standard of care treatments after. So if you actually are lucky to obtain accrual and are, not excluded from the trial, and if you feel that your oncologist's perspective is saying this can actually help, and you feel comfortable with that decision, it's okay. It's a scary journey to take that leap of faith, but from that perspective, I felt very comfortable with how self-assured my oncologist felt about it, and I'm happy that I actually did listen.
So now, how often do you see her? Are you seeing her quite often? Have you discussed, for example, the possibility of stopping the treatment? I mean, did this come up or not really? Because it's clinical trial, so I don't believe you're probably allowed to stop it.
Well, it finally got received to become FDA approved, the medication. And
Can
so
you tell us what the medication is?
it's actually seratinib.
Okay.
Yeah. So, and it received FDA approval. And when that happened, I actually continued to take it as a regular standard of care treatment.
This is amazing. So then you decided to apply, obviously, for the fellowship that you mentioned. How did the experience that you've had with the first oncologist, the second oncologist, being in a clinical trial, shape how you take care of patients? I mean, as a medical resident, you obviously took care of patients. I presume now you're not seeing patients because you're in a research fellowship, but you will once you do the hospice and palliative care fellowship. How is this affecting how you actually interact with patients day in and day out?
I think the most important aspect that has often I like to highlight is that a lab test is not just a lab test for a patient. A scan is not just a scan. There's so much more nuance that happens, and we have to be very judicious in the choices that we actually do. The second thing is that we also have to remind ourselves that we receive a consult or we receive to see a patient in our clinic, and we have to, before we knock on the door, before we pull the curtain, we come back with a list of array of order sets that we have or things that we're going to do to make sure that this patient is taken care of. But in order for us to optimize them, we have to hear first, what is it that's really driving them to be here in this clinic or driving them to be in the emergency department. And once we do that, and we pull back the curtain, by meeting that metric of hearing them, I think that will change how we actually, what tests we order, what things we are going to do. And if we do that, they're going to be so much more happier about their own medical journey and the result of their diagnosis. It's not just a diagnosis that's written in the EMR. It is something that they feel that they've owned, and they actually can start advocating for themselves. It's more focused on patient advocacy in that sense.
Our experience shapes how we really conduct our practices and how, what we actually see. In your fellowship that you are starting at Memorial Sloan Kettering, you talked about the theme of the, obviously, connection with patients and quality of life and things like that, but how is that going to be implemented on the ground? Do you have an idea, how does the curriculum look like? I mean, when you interviewed, you probably investigated that. How are they going around addressing that particular element of the human connection?
Well, I think that's what's so important is that they have effective communication workshops that actually optimize patients that, fellows that are actually going to be focusing on palliative medicine in the lens of cancer patients. But also what I really am truly blown away about Memorial Sloan Kettering is this idea of the 1, 2, 3 project, which is that every cancer patient that actually comes through the door actually gets to see palliative medicine specialists if they would like to understand what their goals and how to align to their goals. And I think that's really the necessary idea to understanding how we are going to look at a person in a 360-degree perspective, not just the diagnosis itself, but also just how do they deal with their day-to-day.
I mean, do you feel, obviously your experience with the first oncologist probably underscores that we could do a better job in communication. Where's the breakdown? I mean, why are we not doing a good job in communicating with patients, in your opinion?
I think it's hard to say because it's hard to define exactly how you said it. It's a feeling, but I think that the breakdown is before we make a comment or before we make a kind of statistic diagnosis on what is the statistics, I think we have to have all the information first. And that will actually help the patient to understand themselves and understanding how do we advocate for our patients, even in a space of a terminal illness. How do we do that? I think that why I say that question is we have to constantly remind that question, because that question will change how we effectively communicate. Understand that this is a terminal illness that is going to be defined, that's going to define their life. And how would you, as the person receiving this information, how would you like to receive that information? With all the knowledge that we do know, as physicians ourselves. So I think that's really important.
Yeah, I couldn't agree with you more, Amish. This is critically important. I also think that physicians are too busy nowadays. I mean, they're seeing so many patients, they are bombarded by so many things, and that's really taken away from establishing that human connection, that human nature. And if there are ways to remind ourselves that really we are in medicine not just for the click, 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 and make sure that we have the diagnosis code, and that there is really an element of this that is really critical to address, I think it would be really great. Have you not thought about thoracic oncology? I would have thought you wanted to do thoracic oncology as opposed to GU oncology.
I'm interested in all solid tumors. I was really fortunate, as you know, when I was completing my medical school training, to work under Dr. Paul, and he really highlighted the importance of shared decision making and also quality of life. He's a big proponent of quality of life metrics as well in the space of genitourinary oncology, and so I felt it was a perfect fit to learn under him. And um, it's also been a life-defining moment of loving that space and learning that there is so much more to learn from. But thoracic oncology, if you know, maybe down the line, I'm not sure. It's still up in the air
Yeah,
for me.
Monty will, once you work with him, you want to always work with him. I'm a big fan. Um, Let me ask you a little bit about shared decision making a little bit, because
Mhm.
there is an element that it's very difficult to have shared decision making when you have imbalance in the information between the physician and the patient. I mean, let's face it, you were a medical student, so you were in the medical field, and you probably were not well versed with the ALK translocation of non-small cell lung cancer and the type of drugs and the percentage and everything. And that piece of information is critical to have that shared decision. I mean, I always feel, a shared decision meaning that you must have enough information to participate in the decision making. And it's very difficult to summarize everything in oncology in a visit. I do feel that shared decision making, if you have two treatments, for example, that the doctor prescribes the treatment and you have to choose between treatment A and treatment B, and you decide based on your goals and what you need and things like that. But isn't it difficult to be, how can you make the decision on a particular serious life-threatening event if you don't have the proper training? I put myself in an example. I'm in the emergency room, let's say, and I'm having a heart attack. Hopefully I won't, but let's say I'm there. I would have no clue whether they should take me to the cath lab so they could open up an artery, they do an open heart surgery, they do conservative management. I honestly wouldn't know. I mean, they could tell me all they want. I'm going to say, I don't know, do what you think is right. I really don't know. I mean, I don't know, because I'm not well trained in cardiology. So help me reconcile that. I'm a big believer in shared decision making, but at the same time, it's really difficult on the patient. It's to participate in all aspects. I think patients can participate in some aspects, but not in everything. Help me understand that.
I agree with you. Not all aspects can be fully talked about in that lens from the perspective of a person who doesn't know medicine. I understand that completely. But I do feel that if we understand what drives them to get, you know, what they actually are, their passions, what are the things that they want to accomplish, will actually help us make a different treatment approach or treatment strategy, whether if they actually can go on clinical trial, or do they need standard of care in that setting? I mean, I think that it's hard to say because, in that situation of an emergency of uh, God forbid, you going to the emergency room and finding out that you have an MI. Yes, there is some part of you that actually has to leave yourself and say, do what you know best. I completely concur. But how we communicate during that piece, that component of saying, this is what we're seeing, this is what we would like to do, and this is the reason why, and what are the complications from it. If we even just give that whole breakdown of worst case, best case scenario, it will make a patient feel so much more of the driver's seat in their care, essentially.
Yeah, very, very important. I agree with you. What else did you want? What led you to decide to share your story? Obviously, this is putting yourself out there, putting your vulnerability out there, sharing your entire story with the world, and something triggered you that you said, you know what, I'm going to write this. I'm going to let everyone know. Was there something that led you to decide to share your story?
I felt that my perspective was quite unique. And, as I was growing to be a physician, I also I was also a patient during this whole perspective. And I really felt that it highlighted this aspect of oncology that's often not talked about. The idea that this special bond that is created through every oncologist or doctor to their patient. And I'm actually an outlier, but not really. I feel that if we align to the milestones that the patient has, and a better outcome can happen. And I'm a true testament of that.
I'm glad you shared your story, Ameish. I learned a lot from you. I think you have so much resilience, perseverance, humility, and I think that it's amazing to get to meet you in person and then to learn from you how important that is. We all stand to be better doctors and better communicators just by simply reading your piece in the Journal of Clinical Oncology and just listening to you and learning from you. So I appreciate you sharing your story. I appreciate you coming on the show and just spending some time with me.
I'm truly appreciative of, again, thank you so much for this opportunity. And again, I'm just honored to be here. Thank you.
Good luck to you. You're going to continue to do well, and I look forward to learning more about your accomplishments at Memorial and then subsequent fellowships, my friend.